Hi, I'm Dr. Bill French. I have no relevant financial relationship existing concerning this lecture here this morning. It would really be a remiss not to talk very, very briefly about COVID matters and how its impact was on the cardiac cath lab in the past year and a half. As we well know, this has affected all of us. At Harvard UCLA, after many revisions to the STEMI protocol, to add fibrinolysis back in a prominent role if necessary, we actually came to the conclusion that the only way to solve this problem was to have the ED attending call the interventional cardiology attending on call for any individual patient who may be a candidate for fibrinolytics versus primary PCI. But in fact, what we landed up doing for the past year and a half is only have used primary PCI in all our STEMI patients with usual good results as illustrated in this case. But we're going to hear more about the COVID-related matters in the future. And obviously the PPE issue with staff became so important for the cardiac cath lab. But today let's focus more on what's new in the cath lab, what we've been doing recently, and I think will continue into the future. First of all, I have some personal insights into the cardiac cath lab as I've been there for a number of years, and nothing is fascinating more than some of the major changes that have occurred. The introduction of PTCA, followed by PCI with stents, and then primary PCI for STEMI patients has revolutionized the management of atherosclerotic coronary artery disease. For valvular disease, TAVR procedures are the most satisfying procedure I scrub in, and the valve can now be used in some other areas as illustrated. Of interest, we've been closing shunts for a number of years, PFOs, ASDs, and so forth, but now we're starting to open and create shunts in patients with heart failure in a new research protocol. So the technological changes keep on coming, and these improvements in technology have been in imaging, in devices, in therapeutic agents that have revolutionized our management of the interventional patient to have it a safer, shorter procedure with better outcomes that have so much improved the patient's condition. Today, what I'd like to do is discuss some issues concerning complex PCI procedures, and I think show how that has revolutionized the management of patients in the cardiac cath lab as well. So let's talk briefly about the difference in revascularization procedures, PCI or CABG, and we're all quite aware of the two very different procedures that they are. In discussing with the patient, obviously, need to open your chest has to be discussed firmly by the surgeon and very clearly. And the use of a large incision, general anesthesia, and so forth are obviously areas where the cardiologist has always wanted to kind of minimize that. And today, I mean, what we see in the cardiac cath lab is a whole different approach to the management of this high-risk subset of patients. So now with the radio procedure, we approach the patient and simply say, may I hold your hand so that we can perform this or that procedure that will benefit you and avoid some of the issues associated with cardiac surgery. And of course, we always had the issue of who is a candidate for CABG procedures. And these two candidates, both for triple vessel disease, are they both candidates for CABG? Will they undergo CABG? And you look at the patient on the left and you kind of think, maybe not this year. And the patient on the right, well, you know, you're never quite sure. Sometimes they go to surgery, sometimes they don't. So I think that the issue is to look at the temporal trends in PCI and CABG for the past 10 or 15 years, and we'll gain insights from the Washington State Cardiac Care Outcomes Assessment Program that was published last year in the Journal of the American Heart Association to try to get some insights. And the data from this trial has been replicated in many other trials, including in Medicare patients. This slide just shows the volume of procedures done either by PCI or CABG. And what we see on the top, going back to 2005 and extending through 2017, is there was a marked decrease in procedures that really reached its nadir somewhere in 2009, 2010, and then plateaued But then in the past 5 to 7 years, we've seen a marked increase in PCI procedures to bring us back to almost where we were back in 2005. As with cardiac surgery, it's not the same picture. The cardiac surgery procedures have decreased dramatically in the past a decade or so. And this has only plateaued without really a significant increase in the more recent past. So a very, very different impact on bypass surgery versus PCI. And if we look at data from this study from Washington State, we see the CABG volume has decreased nearly 10 times more than the PCI volume decrease. So this is a marked change. And why is that? Well, it's not entirely clear. I mean, the Barry 2D and Courage 2 trials failed to demonstrate clear benefits of coronary artery disease revascularization. I mean, the Freedom trial, on the other hand, showed CABG superior to PCI for patients with multivessel disease and diabetes. Then we also had the appropriateness use criteria. It started around 2009, and that placed more formal restrictions on any type of revascularization indications that definitely, I think, had a negative impact on clinical practice. But, you know, a unique finding in the study from Washington State was the increase in volume of PCI in the recent era from 2013 through 17, with a 20% increase in overall PCI volume and over a 30% increase in elective PCI volume. So now what we see is in the PCI world in the past 7 years or so, we're having this marked 20-30% increase in PCI volume, where at the same time, we're not seeing that rise in CABG volume. How can we understand the recent increase of PCI? Well, there's no recent clinical trials. There's no new guideline or appropriate use criteria. In fact, PCI in patients with diabetes and multivessel disease in Washington State actually declined over time from 66 to 54% of revascularization procedures, with an increase in the CABG number actually. But overall, CABG volume steadily declined throughout the entire study period. So if we look now at what is going on in the past 5 or 7 years, we see some remarkable changes that are occurring in the cardiac cath lab. This increase in volume of PCI in the recent era from 2013, really probably to the current present time, is very, very important in the sense that what we're seeing is a marked increase in left main procedures during this period of time. We're also seeing an increase in atherectomy procedures, as well as more patients with CTOs, chronic total occlusions, are being taken to the cath lab, where before these three conditions would have led to bypass surgery. But now, in fact, you can see that these patients remain in the cath lab and are undergoing complex PCI procedures. So what is going on in the cardiac cath lab and what's new? And what I would suggest is really a revolution in interventional cardiology underway. And it's just in the beginning stages. And we'll be looking forward to this continuing in the next decade. Because what we're seeing is the risk profile and procedural complexity increase for the PCI group and decrease for CABG subjects. This is just the opposite of what the numbers looked like 20 or so years ago in managing patients with coronary artery disease. We're also seeing an increasing shift to PCI in higher risk patients and those with acute clinical conditions like acute coronary syndrome. And also, not to be forgotten, is the patient preference for procedures. There's no question that the simplicity and directness and safety and lack of large incisions and generally general anesthesia is a patient positive for going forward with complex PCI procedure versus bypass surgery. So now on a daily basis in the cath lab, we're seeing more left main and LAD disease that actually remain in the cath lab or are returned to the cath lab at a later time to undergo complex PCI procedures, oftentimes involving elective impeller procedure, rotablator, IVUS, kissing balloons, and spectacular outcomes in low and intermediate risk patients that are as good, if not better, than from CABG. So stenting of the left main LAD and bifurcation lesion of the circumflex has led to incredible improvement in patients' condition just undergoing PCI versus having to await CABG. So now frequent daily standard use of interventional devices, the IVUS, impeller, rota, TAVR procedures, occasional ECMO, and certainly a variety of new catheters, balloons, and wires has really revolutionized the management of what we're doing in the cath lab. And these changes continue to occur almost on a daily basis. So we expect to see a lot more use of complex PCI procedures in the future and probably less bypass surgery. So the complex PCI procedures, there's some downsides beside being more frequent. They're more challenging, more time it takes to do the procedure, more resources are needed, like impellers and so forth, more costly procedures, and usually more radiation. Although now with new imaging technology equipment available from several vendors, we're now going to see some very marked improvement in patient safety with reduction of radiation dosing to both the patient and to staff, which will help change and revolutionize the management of patients with complex coronary artery disease. But during this time, we just have to keep in mind that the CABG numbers are down, they continue to stay down, and I really don't see that they're going to be improving or increasing in the near future. Now, the cost of switching to PCI from CABG is the adjusted in-hospital mortality increased slightly for PCI and decreased for CABG, but this simply reflects the changes in patient selection for the surgical procedure. So yes, a little more risk for the PCI and less for CABG, but the selection of patients is very different for PCI versus CABG today than it was 20 or so years ago. So I think complex PCI procedures are here to stay. I believe that the present accurately sees tells the future, according to Dr. Nepal, and I can only heartily agree with that statement. So I think moving forward, another personal insight in the management of patients in the invasive cardiac catheterization lab is that we're seeing the rapid and timely decrease in cardiac surgery procedures, which I expect to continue. And lastly, I just wanted to share with you the stat transfer process concept of calling 911 by a hospital that doesn't have a cath lab, for example. This is an American Heart Association Mission Lifeline proposal for emergency intra-hospital transfer of STEMI patients. I'm fortunate to be the senior author on the paper that has been submitted to the Journal of the American Heart Association. And the bottom line for stat transfer is a patient either calls 911 or comes to the nearest hospital, in this case, a referring facility that doesn't have a cath lab. In the ED physician, using stat transfer processes that have to be prearranged in the community, is they could call 911 and the EMS would arrive at the referring hospital, pick up the patient, and bring them code 3 to the STEMI receiving center to undergo primary PCI. This model could be used for stroke transfer of patients, trauma patients, etc. So we see that these kind of process changes go along with all the technology changes that we're seeing, and thus we expect to see many more procedures undergoing in the cardiac cath lab. So finally, what's new in the cardiac cath lab? I think I can sum up by saying that there's definitely an expanded role of interventional cardiology in managing various cardiac diseases. And I really expect this to continue forward in the next decade. So thank you for your attention. I look forward to any questions you may have in this session set aside. Thank you.